Welcome to today's Africa Healthcare Network Educational Nephrology webinar, and today's series number 40. My name is Egina Francis Makwabe. I'm the consultant physician and nephrologist working with Africa Healthcare Network as the Chief Medical Director. And therefore, I would like to welcome you all to today's nephrology education webinar. And today is a special fireside because we have Dr. Stuart L Goldstein. And because this is a partnership with kidney disease, improving global outcome with Africa Healthcare Network, that we've been able to get Dr. Stuart Goldstein. And we all know that KDIGO has been developing and implementing evidence-based clinical practice guidelines in kidney disease, and it has been helping us a lot in developing our guidelines, especially in the developing world. We normally use the KDIGO guidelines. So today's topic is what is new in AKI, acute kidney injury, from KDIGO guidelines and acute kidney injury. So before we proceed, I would like to read just a short bio of Professor Stuart L Goldstein. He's a Clark D. West Endowed Chair and Professor of Pediatrics and Director, Center for Acute Care Nephrology at Cincinnati Children's Hospital Medical Center in the United States of America. And he's also a KDIGO International AKI Guidelines Work Group member on AKI, Hemodialysis Adequacy, and Vascular access and pediatric nutrition. Dr. Clark, it's so good to have you here today. Thank you so much for joining us.
Thank you, Dr. Agina. I really appreciate it. Good evening to all of you, and I hope all of you and your families and friends are staying safe and healthy in these difficult times. And I have unquantifiable amount of respect for the work that you do, and I'm very honored to present to the African Health Network today. So I was a work group member of the 2012 KDIGO guidelines and a work group chair for the 2020 KDIGO AKI Controversies Conference. So the outline today is I'll discuss the rationale and the purpose for a KDIGO Controversies Conference. There's clearly a method to KDIGO's concepts here, and why we felt it was necessary to have an acute kidney injury controversies conference. I'll review some of the 2012 KDIGO guidelines in brief and the research recommendations that were published in those guidelines. I will discuss also some progress that has occurred over the last mere decade for the 2012 research recommendations, and discuss some major changes between 2012 and 2020. And review the research recommendations from last year's publication and conference. So the Controversies Conference convened in 2019 in Rome, and the executive summary from the KDIGO Controversies Conference was published last year in Kidney International. And you can see those of us who are in the byline were the co-directors or co-chairs for various work groups, but you can see all of the other conference participants from around the world. One thing that I want to state, which was really important, was that this was, as opposed to the 2012 conference, we had patient representatives, adult survivors of acute kidney injury, who really informed a lot of the perspective of this Controversies Conference. And I think that was critical to moving us forward. So why does KDIGO convene a controversies conference? Well, the 2012 AKI guidelines were based on data that were available up to 2011. And since that time, there have really been many landmark studies in both adult and pediatric acute kidney injury. The AKI EPI study, which I will discuss, was an adult acute kidney injury epidemiology study. The AWARE study, which was a pediatric, multi-center, multinational, multi-continental study of acute kidney injury in children, was published. The AWAKEN study, which looked at neonatal acute kidney injury in a multi-center, multinational construct. The Southeast Asian acute kidney injury study, focusing on the epidemiology of AKI in Southeast Asia. And then the Preventing AKI study. The PREV-AKI study was one of the first to look at how to incorporate a biomarker into the management of acute kidney injury in patients who are at risk to decrease acute kidney injury prevalence and severity, was published. And then the nephrotoxic injury negated by just-in-time action study, or the NINJA study, which is a pediatric program that we undertook in the United States to decrease nephrotoxic AKI, was published, and in both a single center and multi-center format. So given all of these studies and many, many others, the determination was that we needed to develop convene a controversies conference to reassess if there has been sufficient advancement to warrant a new guideline and prepare for that eventuality. So these are not necessarily new guidelines from the controversies conference, but they do sum up the advancements that have been made. And I think you'll agree with me at the end of the presentation that there have been enough data and advancement that we should have an updated KDIGO AKI guideline. So this has become our Bible since the 2012, and this was really the first international guideline to direct acute kidney injury epidemiology and management across the world. Again, it was the first international guideline for the diagnosis and management of acute kidney injury, and possibly the most important development and product that came from the guideline was the harmonization of the AKI definition and staging criteria from RIFLE, from the AKIN criteria, and the pediatric modified RIFLE criteria. And we all know this well. We've been operating with this definition now for nearly a decade, but it still was relatively an empiric definition, looking at a 0.3 rise or 26.5 micromole per liter rise of creatinine in 48 hours, or a 50% rise in serum creatinine, or a short period of oliguria. And the staging criteria of 1, 2, and 3, both by serum creatinine and urine output, are well known to us. And then there's a pediatric modifier for stage 3 in kids less than 18 years of age. But interestingly, and what's really important, even though this is the definition of this disease, this was an ungraded recommendation because these criteria had never been tested before and were the summation, as I've mentioned, of RIFLE, AKIN, and pRIFLE. So the AKI EPI study that was driven and headed by Eric Hosta was the first multinational effort to evaluate the KDIGO AKI criteria. And you can recognize many of the names in this intensive care medicine paper as leaders in the field of acute kidney injury in adults. There were 139 units across the world with nearly 2,000 patients, ultimately who were assessed. And in the final data set, 97 programs had 1,800 patients from every continent on the planet, with the exception of Antarctica. So very important that there was African and South American representation in AKI EPI, given the difficulties and challenges with enrollment off those continents and often regulations with institutional review boards and ethics boards in sharing data. And there were a number of models to associate AKI with mortality. And the models included both stage and then other factors for risk for mortality. But what you can see here is that there is a graded stage or a graded association between AKI stage and outcomes and 28-day mortality. As the stage goes up, as the complexity of the patient in each model goes up, with AKI stage 2 being independently associated with mortality, conferring somewhere between a 2 to 3 increased odds of mortality, and AKI stage 3 conferring more than a 5 times risk of mortality. So this study demonstrated that acute kidney injury was independently associated with 28-day mortality in critically ill adults and conferred an incremental association with mortality. In 2017, we published the AWARE study in the New England Journal of Medicine, assessing the association between stage 2 and stage 3 AKI in children and 28-day mortality. We chose stage 2 and stage 3 AKI because in previous pediatric studies, stage 1 or rifle R were not associated with poor outcomes, but stage 2 and 3 or rifle I and F were. This was a multinational, multi-continental study, as I've mentioned, with a North American predominance. Unfortunately, we were unable to enroll patients from South America or from Africa due to the challenges that I had mentioned before. This was a prospective observational study over a 3-month calendar period at any 3 consecutive months within the year 2014. Ultimately, 5,200 patients were enrolled in AWARE. The median age was about 5.5 years. And you can see the primary diagnoses that were associated with the admission to the ICU. We found that there were 16 different variables in univariate analysis that were associated with 28-day mortality. But importantly, severe AKI, so stage 2 or 3 AKI, was associated with mortality on bivariate analysis, whereas 36% of non-survivors had stage 2 or 3 AKI, whereas only 10% of survivors had stage 2 or 3 AKI. And putting this into a multivariable regression analysis, stage 2 or 3 AKI was incrementally associated with 28-day mortality with a 1.77 odds ratio. This is important because children often do not have many of the underlying chronic comorbidities that adults do in terms of heart failure, diabetes, chronic obstructive pulmonary disease that also confer independent risk of mortality for critically ill hospitalized patients. And looking at the Kaplan-Meier curve, we can again see that there's a graded association between acute kidney injury stage and 28-day mortality. And while much of this mortality is driven by the stage 3 AKI, there is still an independent association with stage 2 AKI and outcomes. So when we look at the 2012 AKI diagnosis and research recommendations, the role of biomarkers other than creatinine, and I'll discuss that a little bit later, there's a research recommendation to look at these in terms of early diagnosis, differential diagnosis, and AKI prognosis, because once the creatinine is already elevated, as you've seen, there's an independent association with mortality, and hopefully these biomarkers will be able to help us differentiate the type of AKI, functional versus structural, but or what we used to call pre-renal and intrinsic, but help us focus our efforts on the patients who truly have structural AKI. There was a research recommendation to look at the influence of urine output criteria on AKI staging and outcomes, because it's much easier in these large databases to extract serum creatinine criteria from electronic health records and even from paper records, because they are discrete variables, whereas urine output often is not reliably collected. And then assessing the influence of serum creatinine on AKI staging and outcomes. Well, that's what I've just demonstrated for you with AKI Epi and Aware, and for neonates, Awaken showed the same thing. So now let's talk about urine output. So the first study that really looked at this in a systematic and reliable way was published by John Kellum and colleagues in the Journal of the American Society of Nephrology about 5 years ago. And their source population was about 45,000 patients. They excluded a number of patients because they had an elevated creatinine above 4, or a history of chronic dialysis, or they had inadequate urine output assessment, or serum creatinine assessment to stage AKI. But still, after those exclusions, they had 32,000 patients to be able to assess. And what you can see here is an important finding, that both urine output and creatinine were associated with poor patient outcomes, and that combining them was associated with even worse outcome. So in patients who didn't have AKI, they had a very low rate of mortality in the hospital by 90 days or even by 1 year. In patients whose maximum AKI severity was driven by the urine output criteria of KDIGO, you can see an increase in hospital mortality rates, in 30-day, 90-day, and 1-year mortality rates. And looking at the serum creatinine criteria as well, if it were the creatinine criteria alone that demonstrated or drove the maximum AKI severity, you can see an increased rate of mortality at each of those time points. And if both, so for instance, if patients had stage 2 AKI by both urine output and serum creatinine criteria, you can see a multiplicative effect and an increase of poor outcomes of mortality along each of these time points. Very important to understand that both urine output and serum creatinine have independent and additive associations with patient mortality. And there were a number of models that were based on no AKI by either, say that's group 1, or AKI by stage 1 by creatinine, but not by urine output, which is group 2, all the way down to group 6, which is AKI stage 3 by both. And you can see a graded association with the type of AKI, whether one or the other is involved. And again, if the severity increases in terms of AKI, just a beautiful graded association with 1-year mortality. And the same is true from the development of end-stage kidney disease. So the USRDS is United States Renal Data System. When patients are diagnosed with end-stage kidney disease, you can again see that group 5 and group 6. So if these patients survived, that patients who had stage 2 or 3 AKI had a significantly increased risk of developing end-stage kidney disease at 1 year. Now, in the AWARE study, again, the pediatric study, we assessed the effect of urine output criteria on 28-day mortality in pediatric acute kidney injury. So again, we started with 5,200 patients in the AWARE database, and ultimately we had 3,000 patients with a classifiable AKI status for both creatinine and or urine output. And what we found was that 15% of patients had acute kidney injury stage 2 or 3 by either creatinine, urine output, or both, whereas 85% of the patients did not have stage 2 or 3 AKI by either. What is really important here, again, when we look at the 15% of patients who had AKI by one, the other, or both of the criteria, 18% of patients only had stage 2 or 3 AKI by urine output criteria. So nearly 1 in 5 patients would not have been diagnosed with stage 2 or stage 3 AKI if we didn't look at urine output in AWARE. We're missing nearly 1 in 5. And when you look at the Kaplan-Meier curve, you can see that patients in the group 3 who only have stage 2 or 3 AKI by urine output have the second worst outcomes, and again, we are missing these patients, and these were about 18% of the patients. And patients, just like in the study by Kellum, who had stage 2 or 3 AKI by both creatinine and urine output, had even worse outcomes. So what about risk assessment? Again, we'd like to understand who's at risk for AKI before they develop it, so we could potentially do something about it. So what were the recommendations? They recommended that patients be stratified for risk of AKI according to their susceptibilities and exposures, and that was a 1B recommendation. But again, there were no data to tell us really how to do that. Manage the patients according to their susceptibilities. Well, that was a not graded response. And test patients at increased risk of AKI with measurement of creatinine and urine output to detect AKI, and was, again, not graded, and individualize the frequency and duration of monitoring based on their risk and course. That was not graded either. Now, for the latter 2 recommendations on management and testing, I think the AKI EPI and AWARE experience has addressed these. Again, we need to understand, though, what are the susceptibilities? And the recommended susceptibilities were pretty obvious. Sepsis, critical illness, burns, those were the exposures, nephrotoxic medications. The susceptibilities were advanced age, Black race, CKD, diabetes, etc. But this is not necessarily helpful to the clinician because are you going to get creatinines in every woman who has sepsis, and how often are you going to do this? Or in every elderly patient who has burns. This doesn't give us a construct, it just gives us some ideas. And so the research recommendations were a better delineation, as I've mentioned, of risk for hospital and community-acquired acute kidney injury, and a better delineation of the effects on age. And what I would say as a pediatrician, we shouldn't just be looking at advanced age, but we should be looking at younger age all the way down to our neonatal patients. And so when we start to think of the acute kidney injury paradigm and risk stratification, where we live now, as I've shown you, is in looking at serum creatinine or urine output as the functional markers of acute kidney injury. And the KDIGO recommendations detailed that we needed to understand better about damage biomarkers. And we need to understand, because some of these markers are expensive, that we really need to risk stratify patients better. So what are the qualities of an ideal biomarker? Well, they need to be accurate and reliable. They need to be relatively non-invasive, and they need to be rapidly measurable, and they require a case definition. The KDIGO definition is what we have. And the way we evaluate a biomarker is with something called the area under the curve of a receiver operator characteristic. So a perfect biomarker would have 100% specificity and 100% sensitivity, and would have an AUC of 1. A worthless biomarker, or a flip of the coin, would have an AUC of 0.5. A good biomarker, and that can be a clinical biomarker such as age and bypass, would have an AUC of 0.75. Whereas a really, really good biomarker will have an AUC of 0.9. And there are very few of those really good biomarkers that stand on their own without using risk stratification to improve the potential benefit of utilization of that biomarker. So the first biomarker that was ever used in humans was NGAL, neutrophil gelatinase-associated lipocalin, discovered by my boss, Dr. Prasad Devarajan. And here at Cincinnati Children's, 71 children undergoing cardiopulmonary bypass were evaluated for the development of acute kidney injury, which was defined as a 50% rise in baseline, and to see if NGAL and urine NGAL and urine NGAL normalized for creatinine could predict acute kidney injury. And what you can see on the right here in the blue lines are the NGAL levels in patients who developed AKI, so 50% rise in creatinine at 2 hours, 4 hours, 6 hours, 8 hours, 12 hours, 24, 36, et cetera. And in the red lines are the median levels of NGAL in patients who didn't develop AKI. The first graph is NGAL, the second graph is NGAL normalized for creatinine, and you can see that NGAL comes up 2 hours after initiation of bypass in patients who ultimately develop AKI. And the green bar is when the creatinine started to come up. So you can see that NGAL predicts who's going to develop AKI 24 to 36 hours before the creatinine increases. And the top gels are basically Western blots to prove that this was NGAL that was being measured. NGAL, IL-18, LFABP, and KIM-1 are also other biomarkers that have been studied. And in another study from Cincinnati Children's, looking at 220 patients after bypass, you can see that all of these biomarkers in patients who develop AKI, this time in red, are elevated. But they become elevated at different time points. And so it's likely we'll need to use a biomarker panel in different situations to better delineate the time course or where we are in the time course of AKI for a particular patient. In the adult world, cell cycle arrest biomarkers have been studied in critically ill patients admitted to an ICU. So in this study by Kashani and Kellum, there were 728 critically ill adults where urinary and plasma biomarkers were measured within 18 hours of enrollment. And AKI was defined as KDIGO stage 2 or 3 within 12 hours of sample collection. And what you can see here is that while NGAL and other urinary biomarkers seem to have decent prediction of development of AKI, the cell cycle arrest markers of TIMP2 and IgBP7 and their product had an AUC of about 0.8 and seemed to work much better in adults. And when you looked at the sensitivity and specificity, the AUCs for AKI or AKI stage 2 or renal replacement therapy or 28-day mortality, the cell cycle arrest markers had moderate to very good prediction of these various outcomes. So now we have these biomarkers, and so maybe we should go ahead and get them in everybody. Well, how do we use them? First, this is the PREV-AKI study that I discussed with you. So this was a study by Mirsch and Zarbach, a single center study that looked at adult patients undergoing bypass with cardiac surgery with bypass. High-risk patients were defined as having elevated TIM2 IgBP7 product for 4 hours after the termination of bypass. The control patients received standard of care, but the intervention patients received a KDIGO bundle, avoiding nephrotoxins, discontinuing ACEs and ARBs, close monitoring of serum creatinine, avoidance of hyperglycemia, and close hemodynamic monitoring. So only in the patients who had elevated cell cycle arrest markers got randomized. And so here's the optimization of volume status that was directed. And this is obviously a very, very intensive management strategy. And you wouldn't want to necessarily perform this in patients who were not at risk for acute kidney injury. So this is where the biomarker helped direct resources in patients truly at risk. And what you can see here is that control patients, so those who had elevated cell cycle arrest markers who did not receive the bundle, had about a 72% rate of AKI and a 44% rate of stage 2 or 3 AKI. Whereas patients who had the intervention had reduced all AKI to about half and to about a third of patients having moderate to severe AKI. So this is the first study that demonstrated a biomarker directed strategy could improve outcomes. So again, these biomarkers are great. I don't know if you guys know who Tony the Tiger is, but he's an icon here. But we should get them in everyone. And what I would say is we need to keep calm and hold our horses. First of all, because cardiac surgery is not the same as everything else we see. Cardiac surgery, we know the timing of the insult, we know that there's a high rate of AKI, whereas in the cardiac surgery study by Mirsch and the study in Cincinnati Children's, we know the timing there. We need biomarkers that help us in more heterogeneous populations that are at high risk for acute kidney injury. So the land of AKI biomarkers has also become told or characterized as worship of troponin for the acute coronary syndrome. But we need to think about that syndrome. That's a set of symptoms in the appropriate individual that causes suspicion for acute kidney injury. And it's the clinical context that leads to the appropriate biomarker assessment to rule in or rule out the MI in an at-risk individual and in symptoms that raise suspicion for the MI. And the lack of the anginal equivalent should inform us to not use the biomarker. So if we look at troponin in patients who don't have the classic Framingham risk factors, say in sepsis or septic shock, troponin is elevated in 80 to 90% of septic patients, and they are not having a heart attack. So this is not the right population. And in fact, troponin is elevated in a number of non-cardiac related, non-myocardial ischemia related syndromes. So if you have a patient, say, who presents to the University of Cincinnati adult ER on a cold Cincinnati day, who's 35 years old and very fit and is shoveling snow and has chest pain, that patient doesn't have the right set of symptoms to warrant getting a troponin. They probably had some trauma to an intercostal muscle. Or if you have a patient who is diabetic and obese showing up to the University of Cincinnati adult ER with toe pain, they're not having the right symptom of chest pain, of radiating chest pain, and you wouldn't get a troponin in that patient. So again, we need the classic risk factors, the Framingham risk factors for the acute coronary syndrome, clinical signs and symptoms, ancillary test, and the biomarker of troponin to then say this is a patient with the right symptoms, with the right history, who now has this elevated test, and this is a patient who needs to go to the catheterization lab to hopefully abort a myocardial infarction. So how and in whom do we apply these AKI biomarkers? Well, AKI does not have a specific symptom set to prompt evaluation. On the first day of medical school, I was taught by an anatomy professor, Dr. Ernest April, there are only 3 reasons that people go to a doctor: fever, bleeding, or pain. No one wants to come to see us if they don't have fever, bleeding, or they're in pain, right? So AKI is not associated with any of these. Simply put, AKI doesn't hurt. So Mink Chawla, who's an adult intensivist and nephrologist, and I came up with a concept of renal angina. And what we want to do is identify and stratify the at-risk population, combine this with clinical signs and or kidney function changes to direct biomarker assessment. And as with the MI paradigm, the negative predictive value for AKI of not fulfilling these criteria should be high. And so we developed some risk stratification. So patients who come into an ICU are considered moderate risk for AKI. Patients who are high risk are those who have undergone cardiopulmonary bypass or have a stem cell or solid organ transplant. And patients who are very high risk are intubated and on a pressor, a vasoactive substance. And then we multiply that by the chest pain, if you will, change in creatinine in the first 12 hours or decrease in urine output or development of fluid overload. And so now we have a number of risk factors. We have what the angina threshold will be, and that should direct the biomarker assessment. And so we studied this in children first. We had a derivation cohort at Cincinnati Children's and then 3 validation cohorts. And the primary outcome was, could what we called the renal angina index in the first 12 hours of ICU stay predict KDIGO stage 2 or 3 at 3 days? Not by 3 days, but was it persistent? Did these patients develop AKI that was persistent at 3 days, or do they have AKI in admission that was still persistent at 3 days? And so the renal angina index integrated the risk level and the injury status and gave it a specific score. And renal angina ruled in if it was greater than or equal to 8 based on our initial cohort from Cincinnati Children's. And what we found here, both in the derivation and then the 3 validation cohorts, is that the AUC was actually pretty good, just as good as any biomarker to predict stage 3 AKI, but there was a high negative predictive value. So it was good at ruling out, just like in the MIRSH study, ruling out the risk for AKI. So now we only had about 10% of patients who were at risk with an RAI, renal angina index greater than or equal to 8. And so now that's who you can focus your attention on. And in fact, when we looked at the 4th group of patients, a sepsis group, you can see that the RAI had a much better AUC than NGAL or other biomarkers. But that's not the point. What we want to do is add the biomarkers to the risk stratification. So only in patients who are positive, that's who we want to get the biomarker in. And in fact, the prediction of acute kidney injury improves when we add biomarkers only to patients who develop, who are renal angina positive. We looked at this in the AWARE population, and what we found was that renal angina, being renal angina positive, again with a value of 8 or greater, was better at predicting AKI than a change in creatinine itself. And so this tells us that we're incorporating a lot more than just the change in creatinine, which we know can just be from dehydration and not true AKI. There's been a meta-analysis now, a systematic review of the renal angina index in children with 21 studies that have evaluated this, and 12 of which met, or 14 of which met the criteria for being adequate. And you can see a very good AUC of about 0.8 with a 8.8 with a good sensitivity and specificity. Now, the adults were not far behind us. So Dr. Ortiz Soriano and Javier Neira from the University of Kentucky and UT Southwestern modified the renal angina index for critically ill adults. And what you can see here, and this was just published this year, is that in both the derivation and the validation cohorts, the adult modified renal angina index score had, again, about a 0.8 AUC to predict AKI in the first 7 days in their cohort. And again, better than a change in creatinine. And their score seems to have a value of 10 instead of 8. That is the threshold that should direct biomarker assessment. And here you can see their score, which, again, this doesn't really apply to children, things like diabetes. Sepsis certainly does, and we have a sepsis modification now for the pediatric score, but you can see here where the risk really starts to skyrocket when the multiplicative factor goes above 10 or 20. So, what are the risk recommendations from the Controversies Conference of last year? Newer developments related to, monitoring and evaluating risk progression, including e-alert systems, machine learning algorithms, and artificial intelligence for recognition and monitoring. And that is what the renal angina index and biomarkers have done. And we need to now do this in more prospective fashions and with larger multi-center work. This was the most important figure from the KDIGO stage management guideline, and you can see most of these still hold true. But now we have better understanding of who may be at high risk with renal angina and biomarkers to help us. This was the guideline for specific management back in 2012. And while it's completely verbose, I might say, in its writing, it needed to be, because remember, we did not have a guideline, and so we really needed to set the stage. But what I want to go through here is to show you that a lot of this was based on stuff that is pretty obvious in our 2C, 2D recommendations: protocol-based management, targeting glucose control, nutrition. So it was important to codify these so people could start to work on refining them, because these recommendations didn't exist in one place ever before. And then a lot of these are stating things that we should not do. Don't use diuretics to prevent or treat AKI. Do not use low-dose dopamine. Do not use phenoldipan. Do not use a atrionatriuretic peptide. So these are a bunch of don't do's. And this was helpful because people were continuing to do this as part of standard of practice, standard of care practice, and none of these interventions ever were demonstrated to be helpful, and in many cases were deleterious. And then a lot about aminoglycosides and how to manage aminoglycosides and assess acute kidney injury in aminoglycosides, and some on amphotericin. So again, these are very basic and not terribly sexy, I may say, but were important to set the stage of what a standard of care should be. Also, they suggested bypass should not be selected solely for the purpose of reducing perioperative AKI or RRT, and not using N-acetylcysteine to prevent AKI in critically ill patients or after post-surgery. So there was, in the 2020 controversies conference, there was little mention of contrast-induced AKI, as opposed to an entire section on 2012. And in fact, there was very little discussion of nephrotoxicity in 2012. There was discussion of hemodynamics, a much more vigorous and robust assessment of nephrotoxin management, and I was the co-chair of that group, of fluid management, and much more robust discussion, not of how to prescribe RRT, but of when to think about prescribing it. So here is the figure that is looking at nephrotoxic medication-associated acute kidney injury with a number of susceptibility factors. And you have on the bottom left recapitulation of the ADKI 2x2 table of dysfunction without injury. And these might be ACE inhibitors that may cause some dysfunction that really isn't nephrotoxic. And there's injury without dysfunction up in the top right. Those are the things we classically think about as tubular damaging drugs. And then patients who have dysfunction and injury. And then we need to think about deleterious risk modifiers that make these worse, or interventions to mitigate risk. And these strategies for a drug stewardship program to prevent AKI and acute kidney disease, I think, are really helpful. Now, most of them are well known to us, but the two that are the most important, if you can, is include a clinical pharmacist for drug stewardship, because these specialists can really help us modify drug dosing and combinations to decrease the burden of nephrotoxicity and decrease the rate. And then undertake a dynamic prescription and medication reconciliation at transitions of care. What's really important when critically ill patients or even hospitalized patients go out into the community, and what the patient care representatives at this conference told us, is there's a very poor job of doing medication reconciliation and even training or teaching these patients why they're taking the medications they're taking. Remember, these patients have been critically ill, have had a traumatic experience, and are not likely to remember half of what we teach them in the hospital. In terms of the schematic diagram for renal replacement therapy, There needs to be a medical evaluation, severity, biomarkers, dynamic testing like the furosemide stress test, fluid status, and then there needs to be shared decision-making, and there may be withholding of RRT if this is thought to be futile. And then but you also have to think about resources. And this was especially important during the height of the COVID pandemic, trying to understand resources and the available resources and the utilization both of personnel resources, but also machine resources. And I know that in the African continent, acute kidney injury is often supported with peritoneal dialysis as out in non-tertiary care centers as a life-saving modality. And I can tell you in the United States and Europe, a lot of our European colleagues had to learn again how to do acute peritoneal dialysis to save patients when hemodialysis or CRT resources were scarce. And so to end, there are a number of summary points for all of the various work groups. In risk assessment, there's a consensus that we need risk models, and in fact, we've shown that there's some risk models that can be tested. There may be new ones, and we need additional endpoints beside mortality and CKD. And we need better, for research, we need evaluation of AKI risk models and better endpoints. For diagnosis, we need to retain the KDIGO criteria, but they need to be refined. Preclinical or subclinical AKI, biomarker positive and creatinine negative AKI, and better markers of true functional AKI, like real-time GFR measurement or kinetic GFR. In fluid management, and I didn't have time to go through this, both what adequate hydration status is, but using different types of fluid, 0.9% sodium chloride or normal saline versus balanced solution. Using balanced solutions may have an incremental improvement in mortality and development of AKI. Hemodynamic management and becoming much more precise in how we and individualized in the way that we manage the hemodynamics of a patient with AKI, especially in different scenarios. COVID is a very different situation compared to other diseases that cause acute kidney injury. We only scratch the surface of drug stewardship, and I think this is going to be a major focus because this is within our power to affect outcomes in patients and prevent acute kidney injury and prevent chronic kidney disease by being really meticulous with the drugs that we use, looking for alternatives and decreasing the burden. And then finally, looking at the downstream effects of renal replacement therapy and the recovery after RRT. Are there things we can do to promote recovery? Are there biomarkers that can help us identify recovery and help us prescribe CRT, again, on a more individualized patient basis? So in summary, I think it's clear there have been major advancements that have occurred since the publication of the 2012 AKI guidelines. The validation of KDIGO AKI diagnosis and staging criteria, including urine output, have been demonstrated. There are risk stratification systems that seem to hold promise. Nephrotoxic medication stewardship, again, I think is within all of our reach in any setting to assist. Fluid management strategies. And what I think has been really helpful, if you remember, there were a lot of nots. Do not do this, do not do that. And many times when you just tell people what they shouldn't do, that can lead to a perspective of nihilism. And I think what 2020 showed us is that we're now focusing on what can be done, what needs to be researched and improved so that we can reject nihilism in our field. So I want to thank you very much for the opportunity to speak to all of you. And there are a few minutes. I'm happy to take any questions or comments if you have anybody. Thank you so much.
Wow, thank you very much, Professor Stuart. That was excellent presentation. I really enjoyed it, and there are a lot of new things that personally I've learned from you.
Great.
Yeah, so it's time for questions and comments from the audience. Professor Stuart, we have the audience from all over Africa. So the audience is quite big and diverse. Great. So yeah, so maybe I can start with one of the questions. Professor Stuart, it was not very clear with the renal angina index, and because you were involved in this study that was published in New England Journal of Medicine, I think, and therefore it showed promising results, and it was actually even equal to or better than some of the biomarkers. So I wanted to know exactly what is what is the stance? Are we going to use it? Or is it going to be recommended by, because at the KDIGO is not recommended yet, but probably you are there. What's the plan in the future for this?
Well, my hope is that renal angina index gets recommended. At least it was mentioned in the controversies conference. And what we're doing right now, Dr. Egina, is we have an automatic system in our hospital in Cincinnati Children's, which automatically calculates the renal angina index. And if the index results at 8 or greater, then the urinary biomarker NGAL is automatically ordered. And what we found is that we are able to improve the positive predictive value and the sensitivity of the test from about 33% to about 66%. And then this now allows our intensivists, when they see an elevated NGAL in this population of our renal angina index positive patients, they now know that they go now down to a different fluid management strategy because they know they're at really high risk of becoming olivuric and needing renal replacement therapy. And so they're happy with it because we're not telling them to get NGAL in everybody. They're getting NGAL in about 9 to 10% of the patients who would really benefit from it, which is why the risk stratification system does better. And then you add the biomarker to it, and together they're better. And then you can do functional tests like the furosemide stress test. Our hope, and my honest hope, on the day before I retire, which I guess will be in about 10 years maybe, is I want to make the renal angina index available to anybody in the world. And so that you could log on with your computer or smartphone, you could put and the cloud would extract the patient data, would then instantaneously give you back the renal angina index score. And then based on the resources you have, if you have biomarkers, if you have or not, or if you have some other diagnostic techniques or not, would give you a pathway to say, here's the best way, the next potential best 1 or 2 steps to manage the patient, as well as what are the nephrotoxins, and say, this combination has been shown to increase the risk of acute kidney injury. Maybe consider changing to this, not to change your care, but to give you more information at the bedside. So long answer, but that's my pie in the sky moonshot that I hope we get to, because I want to share what we're doing with everybody across the world.
Thank you, Prof. That was a very good answer. So we are eagerly waiting for that.
Yes.
Time to come.
Yeah.
All right. So any comment, question, Professor Stuart?
I think there's some in the chat, so I'll try to do my best if that's okay. Let me see.
It's okay, Prof.
Yeah. Okay, so I'll start. Okay, can we calculate eGFR when patients have AKI episodes? Yeah, that's a very, very difficult question, right? Because creatinine is dynamic. We're hopeful that we'll have non-invasive ways of measuring GFR. I'm working with a couple of companies to do that, to measure it transdermally. But the best you can do is to use MDRD or CKD epi. Again, though, the eGFR and also look at a paper on the kinetic GFR, because that may help you a little bit more with drug dosing, but that can be quite complicated. So yes, this is a major gap in the field. Is there a way of predicting risk for CKD in a situation of severe AKI? Yes, there is. There are a number of studies, especially from the US Veterans Administration and also Kaiser Permanente, that can give you risk factors to identify patients who are at risk for developing chronic kidney disease. And there's a paper that I just reviewed and was just published in Kidney International Reports that I recommend to you. I wrote an editorial for it, just published this month, which demonstrates the trajectories of chronic kidney disease, which is really important, and demonstrates that at 1 year, you can, after an AKI episode, you can kind of understand the trajectory for that patient in developing CKD and hospitalizations. So there's a lot of modeling work being done, but yes, there are ways, there are papers that can show you that. Dopamine is not recommended because in randomized studies of dopamine in AKI in patients who had after bypass as well as after abdominal aortic aneurysm, dopamine was actually demonstrated to be associated with increased mortality and AKI. How does nephron mass impact the outcome of AKI? Great question, Dr. Bhima. And we think nephron mass is hugly important. And I think what your point, to expand it a little bit, is in patients with their renal reserve. So yes, preterm and term infants will have lower nephron mass, but patients who have underlying unrecognized chronic kidney disease, who have decreased renal reserve, are at increased risk of AKI. And Claudio Ronco demonstrated that in an adult cardiopulmonary bypass study where he gave a protein load to patients prior to cardiopulmonary bypass and demonstrated that those patients who could not increase their GFR, who had decreased renal reserve, had increased rates of AKI. So I think that we're going to need to do a lot of work for risk stratification based on renal reserve to protect patients from developing AKI and those who have decreased renal reserve. Since NAC is used in contrast and remains a controversy, is there any medication that can be used to prevent it? Currently, we don't think so. And the rate of contrast-induced nephropathy is getting very, very low with with isoosmolar contrast, and any studies that were going to show any benefit of contrast-induced of a medication on contrast-induced nephropathy is going to require tens of thousands of patients to be enrolled. So I think it's very unlikely we're going to see a medication in the future. How can we treat AKI induced by contrast? Again, same sort of thing. The best recommendation is, I think, make sure the patient is adequately hydrated, reduce any nephrotoxins that they're getting around the time of contrast, and that's the best we can do. Renal angina biomarker used with AI needs data, bootstrapping, and classifier system. Could there be possibilities for errors and predictions? Again, I think thank you, Dr. Vincent. I think what we need to understand, and I think where nephrologists often hurt ourselves, is that we are looking for the perfect algorithm, which just doesn't exist. You want the perfect algorithm in AKI. You want the perfect algorithm, say, for a patient who has a very specific cancer and that a drug, say, that costs $1 million over a course is going to be effective for them. You don't want an algorithm. You want an algorithm to tell you that patient is the right patient to get that drug. In AKI, we want these algorithms to be more population-based, to say, these are the patients I don't need to worry about. Now let me get a biomarker to improve the prediction of who I do want to worry about, and let's calibrate those biomarkers. And so we've really looked for negative predictive value in our risk stratification systems, because in a population-based methodology, that's where we've trained our systems. I hope that answers your question, Dr. Vincent. I'd love to talk to you more offline about it, because this is a real critical issue as we develop risk stratification systems. GFR in children below 2 years, yes, very difficult, but what we currently have is the Schwartz formula. Early versus late initiation of RRT. Well, that could take a whole nother other conference, and I'm not from Ethiopia. Yes, and so I'd be happy to come back or refer you to Sean Bagshaw to discuss this. That's a whole hour conversation, and I don't want to delve into those weeds. I am sorry. Thank you, and it's good to understand. So. Sorry that I skirted that issue on early versus late, but maybe ask Dr. Bagshaw down the road.
Thank you very much, Professor Stuart. Yeah, well, I would accept two more question or comments from the audience. Any comments?
One chat question. There's one chat question.
How often do you see cortical necrosis in women developing AKI related to pregnancy? 51% of patients receiving acute RRT at my hospital from OB. You know, I'm in a pediatric hospital, so I just don't see that. So I don't have information that I could help you with there. I am so sorry, Dr. Kalite.
All right. So if no more comment or question.
Yes, Dr. Makwabe.
Yes.
Yes, thank you, Prof. Stuart, for this elaborate talk. I mean, it has been really great to hear that.
Thank you.
My question, I just want to ask, how would you think that the fact that we have a different spectrum of the causes of acute kidney injury when you're looking at the developing countries and the developing world, because we largely see community-acquired acute kidney injury, would you think that this might have an effect on the recommendations that you're giving, given the fact that the evidence were drawn mostly from studies that were done in developed countries? Thank you.
Yes, I think that is a really important question. And one of the things that we absolutely need to look at, for instance, you know, most of the world's literature on envenomations in AKI come from the less developed world. And there's obviously other types of infections that we need to understand. And clearly one of the things that has led, one of the, I would say, harmonizing events has been COVID. And we've learned about AKI and COVID in different populations. And so I think it's very first world and centric for us to think that we can apply critical care, developed world technology assessments to everywhere else in the world. That being said, I think things like monitoring fluid status and being careful about nephrotoxic medications and follow-up for CKD and risk stratification, I think that crosses the entire world. They may need to be calibrated for the individual environment, but even in the, what you would consider, the top places in the world with the most advanced care, some of these basic things aren't being done, and patients are suffering from that. So I think that there's a basis and a foundation in the guidelines that can apply to all populations and countries and environments, and then we need to tailor and calibrate the more advanced recommendations for the individual specific AKI cause that is associated with that environment. Did that answer your question?
Yes, thank you, Professor Stuart. Thank you.
Thanks.
Yeah, Professor Stuart, thank you very much. Dr. Francis, the one who asked this question, is our pediatric nephrologist, very senior in our country. Actually, in Tanzania, he's a volunteer of pediatric nephrology in this country.
Nice to meet you. And again, I have an immeasurable amount of respect for all of you.
Thank you very much, Professor.
Thank you, Prof.
So I think we have come to an end of our today's presentation. Dr. Lloyd, just last one comment, if you have.
No, I just wanted to thank Stuart very much for this wonderful presentation. So many new concepts brought into us, and taking the time off to answer all those questions very patiently. Thank you very much, Stuart. It was a pleasure.
It's a real pleasure. And again, everyone stay safe, stay healthy. I wish the best for you and your families and your friends. And I hope someday we can meet in 3 dimensions.
Thank you. Thank you, Prof. Thank you very much. We appreciate you very much everything.
And we hope to have you on more than one occasion again.
Would be my pleasure and my privilege. Okay. You name the time and place, and I'll be there.
Bye-bye,
Thank you so much. Thank you.
Right.
Wonderful.
Thank you.
Take care.
Very much.
Bye-bye.
All right. Bye.
Bye.